Thank you very much. Good morning. Just a quick update disclosure. After I submitted my CV to the Toshiba folks for preparation of the meeting, I got an email from medical school that I got promoted to associate professor last 2 weeks. So this is why the slides has changed, and I apologize to didn't update you about that. But so move on to the next slide, which is going to be my just trying to see. Perfect. So the disclosure is I used to receive a grant from a giraffe, which is a GU radiology, sponsored by AUR, one of the main programs, educational research programs in society radiology, and I have some disclosure from Toshiba itself and CareStream. So it's interesting, I get money from GE to work on Toshiba projects. And the main core of this talk will be looking at the potentials of a new novel imaging modality that has been around. I think the first papers came within the last 5-10 years, and that's called four-dimensional CT. We all know about 3D CTs with volumetric assessment. The 4D CT adds another dimension, which is a time. And basically what it does, you use a high resolution with a large bore scanner, namely 320 equivalent 1, which was the whole motivation for this attempt. And basically you acquire images in a fast pace, maybe temporal resolution of 0.5 seconds. So if it's done properly, you can actually image motion of peripheral joints. So with this, we try to test this capability on different joints. As you see, there are a bunch of these joints have been listed in the lower part of these slides. The ones that are yellow are the ones that we have attempted to image at Johns Hopkins. I'm going to explicitly talk about the wrist, but I want to let you guys know that we have done equal efforts on other joints that are marked as yellow. The two other one in the center, which is hip and shoulder, we haven't done it, and there's a good reason for it, because they are more centralized, and with the amount of actual effective radiation exposure that I'm going to discuss briefly down the road, the amount of radiation will not justify, at least for them to be used. You need more, and Hopkins is very cognizant on the radiation exposure and the actual utility of these devices. So we haven't tapped that area as of yet, but the other area have been looked at very closely. So wrist 4D CT acquisition, as you can see, we created a dedicated platform. Basically, there was a device that was created by one of the student, BME, and basically we put the wrist in the scanner. We tried to fix the elbow and proportion of the upper extremity, and the only motion part will be from the wrist side. That's the whole goal for it. And then basically we train the patients before they do a scanner, and we make sure they know that they have to do each motion in a particular way, smoothly, during a 5-second time that you give to them. So the motions include supination, pronation, radial ulnar deviation, clenched fist, which is equivalent to the fluoroscopic evaluation of small ligament injuries, and then basically you have radial ulnar deviation for DRUJ assessment. And if the patient suggests that with a very particular type of pain, motion, I get pain or clicking sensation, then I will have them do the exact same thing on the scanner. And one other thing we do also, because this is a new effort, we also discuss it with the patient, and we're going to image the asymptomatic contralateral wrist, which is documented by our plastic surgeon as asymptomatic contralateral wrist. And we do exact same thing. So we have a nice contralateral data acquisition for future project, and this is part of IRB, and we discussed that with the patient explicitly. So, like talking about the radiation dose, this is a very famous slide, has been used by a lot of my radiologists in other areas and in other meetings. This is a Mettler paper in radiology, and I summarize the effective radiation exposure. When we acquire these images, there's a lot of actual radiation exposure. There's a lot, because we created up to 20 or 30,000 images, all volume, high resolution. But when it comes to the effective radiation dose and that K factor, which is assessed or estimated to be 0.0005, and then it's a simple calculation, you come up with an effective radiation dose of up to 1.5 millisievert based on what we have seen as a product, dose product in our scanner when the patient finish the scan. So it's quite safe. It's quite equal to head CT if you want to basically compare to some of those more established CT acquisitions. So moving on, I would like to give you this first example. This is not the first project. It's the first example which we published as a case report. This was the first case that I found it very interesting. That was my motivation to working on this area. It was a case of piezotracheal joint instability. This joint is a very uncommon joint in the wrist to become symptomatic. Usually the symptoms come from osteoarthritis of the piezotracheal joint. It's a very small joint in the wrist, or some associated soft tissue injuries like tendon injuries, like if flexor carpi ulnaris attached to this, and if it's torn, can be symptomatic. Usually it causes medial wrist pain. So we had a case that X-ray, MRI, and if everything else was kind of inconclusive. This is an MRI image. If you show this to a musculoskeletal radiology, they probably won't be able to pick up anything. There's no evidence of OA, there's no edema, there's no evidence of ligamentous injury, and I did not show the FCU is also intact in this case. So when we did the motion, this is fundamentally flexion extension. This is a 3D reconstruction of that motion. So you see explicitly that the pisiform is popping out volarly when the patient does flexion. So there's the instability of this joint. And then if I do the movie, if I can kindly ask our colleagues back there to play this movie for us. Sorry, So you see that the pisiform is popping out, and that's the cause of patient symptoms. This was not diagnosed by MRI, but the surgeon went in and they do the pisiformectomy. They took this small bone out and they reconstruct the medial side of the wrist, and the patient became asymptomatic. So this was my motivation to work on this. So the next project that I did basically was looking at more systematically, looking at the measurements of the piezotracheal joint. The CC accounts for the craniocaudal motion or position, not motion, position. AP is anterior-posterior position. So between flexion and extension, we did a bunch of measurements in both asymptomatic wrist to see in a subject who does not have symptoms, how does pisiform moves, so we can have a nice reference standard using kinematic imaging. That was a systematic way of approaching this entity. So in the future, not just by looking at a nice picture or movie, but also with the measurements and quantification, we can diagnose this entity better. So we actually came up with, we did some inter-observer agreement. We used the double-oblique multiplanar reformation. I'm going to a little bit talk about that to come up with the right plane to measure the craniocaudal and anterior-posterior measurements for the piezotracheal joint configuration. And we also did some inter-observer agreement, but we showed that the AP is more consistent when two observers try to measure than the CC measurement. So we suggest that the first measurement is better. So we acquired this data and we presented it and we published in the Clinical Radiology 2 years ago. And this is a multiplanar double oblique technique that I was talking about. Akin to what we do with the coronary arteries, as I was told, my second fellowship was cardiovascular images, so I tried to marry these two concepts. We use the vital images and we basically do a double oblique multiplanar to go to cross-section of the coronary arteries. I said, okay, we can use the same predefined anatomical landmark on any joint structures and basically write it out from somebody who is like working far away from me to read my technique and basically go from one plane to the other and basically do the measurement, come up with a similar metric. Because these are millimeter or sub-millimeter measurements. So if you choose a plane a little bit differently, measurement will not be as consistent. Still, with all of that, there is some inconsistent in the measurements, but we are getting there with this attempt. So this is an example. We try to basically determine the scapholunate interval, which is one of the most important part that I'm going to talk in the future slides. You see that, we do define the primary and secondary planes, and basically we do our measurements on the predefined anatomical plane. This is an example that we did the same measurements. The top one is the MRI showing minimal signal. It's wishy-washy. Some people say grade 1 or 2 grade strain of the ligament. The two other ones, lower one is the relaxed, which is narrower, and you can see minimal widening, which is a clenched fist, exactly at the same side measurement. And on top part, there's arthroscopy images that shows lower grade ligament injury. This is a scaphoidal ligament. This is the most important intrinsic carpal ligament, scaphoidal ligament. So with this, we did this exercise of 3 modalities, 1 invasive, 2 non-invasive, 1 novel, 1 established. So we demonstrate that, MRI may not be as great, and we know that. I'm going to show you some meta-analysis information that we also did for the MRI, that CT may have a role in this case. So having this background challenges that we had with the MRI, that was my motivation to go back and look at the entire literature of the 3 Tesla MRI and see how they do when it comes to determination of these small ligament injuries, specifically scaphoulnar ligament injury. We ran the meta-analysis and basically systematic review all the papers that looked at the diagnostic accuracy of MRIs. So the results were very interesting. 1.5 Tesla MRI did not show any good. Like the diagnostic odds ratio is 5.56, which is not really exciting. And that was expected. This is the smallest joint in the body. So this is where the high resolution technique, any high resolution technique has the highest chance to shine. And as you see, the 3 Tesla MRI shows much better results. It has a fantastic specificity. It has almost 100%. So it tells me if the 3 Tesla MRI shows abnormality, it's probably there. But if it doesn't show anything, doesn't mean much. Maybe a little bit, but not much. MR arthrography is better. When it comes to diagnostic odds ratio, you have 65, which tells me that the specificity and sensitivity is higher, but MRA is MR arthrography. You have to put a dye in the joint. So it's minimally invasive and has its own complications. So heterogeneity of the data was seen in the 1.5 MRI over the years of studies. And then what we did a meta-regression, and we showed that, okay, the diagnostic, the circles are log of diagnostic, circles of sample size of each of these studies, and you see they plot them for the log of diagnostic odds ratio over years. You see, and this is 1.5 Tesla because this data was heterogeneous. So we dig into it and we saw that when we move from past to the current, the 1.5 Tesla becomes better and better. Not quite equal to the 3 Tesla, but becomes better. And that tells us maybe because of more knowledge from the radiology side, better coils, better post-processing, better description of injuries, and so on and so forth, not just better magnet strength. So the results basically at the end, this is the message from our meta-analysis. We said that, okay, 3T MRI is very specific. If you see abnormalities, great, but if you do not see and the patient still is symptomatic, you have to do something else. It could be invasive procedure like arthroscopy, minimal invasive like MRA, or potentially 4D CT. That's how we introduced the new technology. So moving on to the further attempts to establish this area, I looked at the chronic wrist pain symptoms and scaphoulnar joint motion from extension to flexion, from ulnar deviation to radial deviation, and from relaxed to clenched fist position. And we demonstrate that in the asymptomatic group, there is no change in the SL interval between these pre-established motions. So it's pretty consistent. There's no significant difference in measurements. But when you look at the symptomatic wrist, the measurements are slightly changing between these motions. So these motions can demonstrate dynamic instability if it's done properly and based on our protocol. This is a list of cases that we have basically tried over the last 2 or 3 years. I tried to list them to see what was to give you guys an idea what was the baseline characteristics of these cases. Many of them had history of falls, chronic injuries. Some of them had MRI that showed some possible signal abnormalities. Some of them did not have MRI, and few of them had also arthroscopic proof of the injury. So we went based on the symptomatic versus asymptomatic, and there was a lot of limitation on this conclusion. But just based on symptom, we tried to categorize our cases and do the measurements. So this is an example. As you can see, we did a double oblique technique and for that determination. The second work that we put after this first attempt to show the differences, we wanted to see if the measurements, scaphoulnar interval measurements, have association with radiocarpal osteoarthritis. So basically what we did, we retrospectively look at all of our 4D-CT, which was about 30 scans, 30 examinations, and basically we remeasure all of them with 3 strategies, and also one other separate radiologist looked at the radiocarpal joint independent numbers and grade the radiocarpal osteoarthritis for the KL grading. So with that in mind, we used 3 strategies. This is interesting. So the first one was a static CT. It's like a regular CT. Do the measurements and see how that measurement is associated, can determine the presence of radiocarpal osteoarthritis. Because at the end of the day, the one thing that surgeons, radiologists, clinicians, everybody wants to do is prevention of that secondary osteoarthritis. That's the end outcome. We don't have follow-up data because that's expensive and it's time, but at least at the cross-section, we have to see something that motivates us for bigger studies. So the second one was the CT scan, CT static, and other position like rest, flexion, or deviation. The reason is because somebody may say, okay, why you scan 11 times the wrist every 0.5 seconds? You can do one static and one flexion or extension, and with 2 acquisition, you may get the equal data. And then basically the third one, which is dynamic, was a change from rest to clench, change from flexion to extension, and change from radial to ulnar deviation. So that's the third one is the actual data that we can get from the 4D CT. So these are the results. As you see, the AUC, the area under the curve, basically the higher the number, the closest that number is to 1. For my colleagues who are not familiar with the stats, that means that it's most accurate. So if it's 1, it's a perfect test. So as you see the lower one, you see that the AUC is going higher, up to 7.77 for the radial deviation to ulnar deviation, interestingly. And then the base one is like AUC is 0.68. That's a static measurement. So you see some increase in accuracy of adding these strategies for determination of presence of radiocorpal OA versus no OA. And this is a comparison, model comparison. As you see, number 1 is the base model, which is a static. Number 2 is a base plus 1 other static. And number 3 is the actual 4D CT. So 1 versus 2, you see a kind of trend, and some areas is significant. But for 1 versus 3, all of them are kind of significant. And you see the differences in AUC. It's up to 0.1, 0.09 from radial deviation to ulnar deviation. So that tells us, hey, 4D CT can have some added value to a static 3D measurements. This is an example. This is a normal wrist, as you see, from the one position to the other position. It doesn't change much the scaffold unit interval. We again use the double oblique planning to basically come up with these measurements. And then when you move on to the next one, this patient obviously has a ORIF of distal radial fracture. We used again double oblique technique, and you see that slightly wide the scaffold unit interval using a multiplanar double oblique technique measurements from one side of motion to the other. And that basically an example showing the added value of dynamic imaging. So we all talked about bones and bone configuration, bone borders, but if you are using a fantastic vital images and all those post-processing techniques we have with acquisition and basic demonstration of the pathologies, you may be also diagnose and assess risk for ligamentous or tendon injuries. I just wanted to put this example as my last slide just to emphasize on the fact that, of course, MRI is better for soft tissue assessment, but do not ignore the amount of pathologies that you can assess. This is actually the post-processed image 3D. Under motion, the patient did motion of the wrist. During the motion, if I can convince you, that extensor carpi ulnaris, that tendon. Can I have a pointer? Is there any pointer?
It's on there, so start.
The start, okay. So yes, that's perfect. Thank you very much. So can you bring it back, please? So if I can convince you that this is a tendon that is in the groove, and when you move the wrist, it pops out. And that was exact sign of the patient's symptoms. Patient had clicking, and then we found it, believe me, accidentally, but we discussed it with our surgeon, and they did the reconstruction of the ECU. So it can have some soft tissue values. So the take-home point, high-resolution 3D MRI is a study of choice for imaging of the wrist, that's for sure. 4D CT can be considered if you see the following items. That's the most important part of this talk. So you cannot replace the 4D CT with MRI. That's I think is not a smart way to move forward with this new technology. If there is an inconclusive plain field MRI, patient has continuous pain, 3 months worth of pain, a lot of disability, and you see that this plain radiograph doesn't show much in terms of malalignment, 3D MRI doesn't show any evidence of ligamentous injury, so that is out. You don't have anything else. So there are three other options. MRA, which is putting a dye, doing another MRI, which is expensive and is minimally invasive, is a risk of infection. Arthroscopy, which is definitely invasive, has a lot of good list of complications. And this 4D CT with minimal radiation exposure, effective radiation exposure. And I would encourage my colleagues, if they want to do these measurements, instead of just visual assessment, looking at the widening or narrowing or popping out or popping in of the small bones, go toward more systematic way of defining measurements. So when they publish their work and present their work, somebody like me across the world can read their work and basically follow their protocols so they can come up with the same number and same measurement and basically prove the concept. Well, thank you very much for your time. I tried to make it very quick, and just here, it's very important for me to say thank you to all my colleagues at Johns Hopkins Medicine Surgery who helped me to navigate through this project. Obviously, as a radiologist, you don't have your hand on the patients. So the big part of it is the strong, enthusiastic clinical colleagues that can help you to recruit these cases and come up with this project. So Jamie Shores, Scott Lifchitz from Department of Hand Surgery, we did 30 ankles, which I haven't discussed on today. It's had another talk. Lou Sean and Casey Humbret. Lou Sean is a past president of Foot and Ankle Society, Surgery Society, very well known. Dr. Kazgaria is actually president-elect of Society of Sport Medicine Surgery. He's a patellofemoral guy. He published several papers right now on the patellofemoral kinematic with Dr. Kazgaria. So I've been a very lucky man working with this amazing group. And the last but not the least are the small but very smart member of the group who actually conduct all these projects, help me with the statistics, and basically they are the people who deserve the most credit. Dr. Hafezinejad and Dr. Wyatt are my current postdoc fellow, which deserve some recognition, definitely some great recognition on all of these works. Well, thank you very much for your time and your attention.